We have a lot to talk about today in light of the value-based purchasing. We are very excited to be able to help begin to shed some light on what could be coming or what we anticipate coming. For the ones especially that have not been involved in the value-based purchasing pilot that has just finished years 1 through 5. We are going to talk about some of the results from the past 5 years, and we are going to get into what has been proposed in the proposed rule, and therefore what we anticipate to be the case come January 1st. So we're going to begin with the framework of basically what was meant to be accomplished by the value-based purchasing model demonstration. It was, of course, required by the Affordable Care Act originally, and part of the Institute of Health Improvement Plan to improve patient outcomes. The model's specific goals you see listed on the screen: to provide incentives for better quality with greater efficiency, study new potential quality and efficiency measures, and enhance the current public reporting process. So as we went through this demonstration for the past 5 years, which took place in 9 states, there was a huge range of what agencies had at risk meaning the percentage that could be taken from their payment or could be added to their payment. Over the course of that 5-year demonstration, those percentages ranged from up and down of 3% in the very beginning to up and down of 8% in the final year. As we will discuss in a few minutes, that final year is technically not even going to count now because of the public health emergency. Some people are happy about that, some aren't so happy. And so we will talk about that in just a few minutes. Payment adjustments are going to be based on the total performance score. This is the way it was in the demonstration. This is the way it will continue to be should this value-based purchasing model be rolled out in 2022 as it was proposed, using measures from OASIS, CAHPS, and claims data. Now, number 2 on the screen is the 3 new measures that agencies during the demonstration had to report on in the value-based purchasing portal itself. So the OASIS answers obviously come from OASIS that have been transmitted. The CAHPS surveys from your surveys that have to be administered through your survey vendor, and the patients or caregivers returning those. And then the claims data, of course, is from your claims data. These other 3 measures were extra things that had to be submitted in a value-based purchasing portal. Good news is those 3 extra or new measures are not going to exist under the nationwide rollout. So that's a really good thing. And we're going to look at the exact measures that are going to be used in the rollout in just a few minutes. So these next few screens are from the 4th annual report, which would have been through year 2019, which was the 4th year of the value-based purchasing pilot or demonstration. As you see on the screen with the map, the states that are in gold are the states that were participating in the value-based purchasing pilot or demonstration for the last 5 years. As you can see, the percentages include the percentage of home health agencies that were in the entire demonstration states, with Florida having 47.4% of the agencies that participated in the demonstration. And so it was a little lopsided, as you can see, but that's obviously because of the volume. So the other 2 highest volume states are Texas and California, and neither of those participated in the VBP demonstration. So having said that, some of the results of this demonstration are the very reason why we are having conversations now and this webinar is happening today. And they're doing this nationwide rollout. And so the results from the first 4 years, year 2016 through 2019, included that they saved the Medicare program $604 million, specifically 381 million of those 604 million was due to a reduction in inpatient hospitalizations. Now, some people find this extremely hard to believe, meaning they believe that likely there was some reduction in rehospitalizations, right? But to believe that we saved $381 million is crazy. But then they tell us that that's only a 2.4% reduction in inpatient hospitalization. So pretty crazy to even think about the fact that a 2.4% reduction in the rehospitalization rate is going to save $381 million. But the reality is those are the numbers. So they've also saying that 164 million of that was due to a 4.2% reduction in skilled nursing facility admissions. And there was actually an increase in emergency room visits. So while there was an increase in emergency room visits, they did have a reduction in hospitalizations and skilled nursing facilities. And this is all specific to the 9 states that were participating in the value-based purchasing demonstration. So what we need to take from that is, and CMS's reasoning for making this a nationwide rollout is that in 9 states, they saved $604 million in 4 years by keeping more patients out of hospitals and skilled nursing facilities. And so if they can do that in 9 states, how much money can they save if it is rolled out nationwide? And so I think you can see, like it or not, their justification for having rolled this out into a nationwide event. They did the total performance scores, if you look on the quality and utilization side, were 8% higher among home health agencies and value-based purchasing states than those in the non-value-based purchasing states. And when they talk about performance scores, they're talking about the calculation of the outcome scores, with the majority of the value-based purchasing items being also included in the outcome calculations of star ratings, et cetera. And so 8% higher in those agencies in the VBP states. So when we look at the key points that came from this report, you see again the $604 million being the key point, key points about money, right? And the impacts were observed during 2019, the second year for quality-based payments, as well as the initial 3 years of the model. So that point being, there was a major change in the value-based purchasing demonstration in the 3rd year, and that 3rd and 4th years or the 4th and 5th years would have shown the impact of those significant changes. And some of those significant changes are going to roll over into the nationwide elements, and we're going to look at those in just a few moments. Okay, so anytime you see this SHP label at the bottom of the screen, this is data that came from strategic healthcare programs that they have given us permission to use, as long as we give them credit, of course. SHP is a nationwide data collection organization. They are also a CAPS vendor, and they do OASIS scrubbing and data collection, as well as billing collection. So the SHP data, this is specific to the 3 states, Arizona, Florida, and Iowa, that participated in the demonstration. And this screen specifically is showing the 25th, 50th, 75th, and 99th percentile with the total performance scores, which I'm going to talk about in a few moments. And from 2018 to 2019, with 2019 being the first year of the major changes that I talked about a second ago. So the major changes, again, impacted 2019 and 2020. They're not going to use the 2020 data now, and we'll talk about that in a minute as well. So as you can see, in Arizona, there was a decrease between 7% and 10.8% in each of the percentiles, and that decrease in the total performance score. The Florida agencies show basically a 7% decrease across the board, or change in total performance score, not percent. And then Iowa, even bigger. These changes, again, primarily because of multiple elements that were changed within the network of how value-based purchasing was calculated. So one of the things that you will find interesting is that most of the time when CMS does a demonstration of any kind, they put it in place, people get together or let it roll out, and it goes. And they don't think about it until the 3 to 4 to 5 years of the demonstration are finished. And then they do analysis on the documentation. And that has not been the case with this value-based purchasing model. This value-based purchasing 5-year model had changes to it every single year. They constantly evaluated and looked at and massaged and made changes, et cetera, to the document, to the methodology and to the things that were included in value-based purchasing. And so we felt like during the process of these 5 years and all the changes that they were making, et cetera, that we were likely going to see some rollout of this as we began to approach the end. And indeed, that is exactly what is transpiring. And so we also, I also find it really interesting that CMS has said that the home health value-based purchasing demonstration is the only one that has worked, meaning they have done value-based purchasing in other provider settings and hospitals, et cetera, but the home health one, they're saying, is the only one that has seemed to work as far as being advantageous to CMS and being able to recoup lots of funds. Some more SHP data. This is from the states you see across the bottom of the screen that were participating in the demonstration. This is from the CMS data. This is not technically SHP data, as you see at the bottom. The reference is payment year 4 for the payment adjustments. These are actually the TPS scores. And as you look across these, you can see that Washington State actually had the highest of the total performance scores, where Florida probably had the least across the board. And these 3 are the 25th, 50th, and 75th percentiles in the calculations. So what's so interesting about this information is if you go to the next screen, where they have applied the linear exchange function, and at the end of the presentation today, we're going to go through the linear exchange function, how it's calculated, how it's used in the value-based purchasing model. It will be used exactly the same way that it was used in the demonstration, except the volume of agencies is going to be much more because it's a nationwide situation and not just states. I don't know that I said this earlier, but within the value-based purchasing demonstration, only agencies in Tennessee were compared to other agencies in the state of Tennessee. In Florida, those agencies were only compared to other agencies in the state of Florida. With this nationwide rollout, you're going to be compared to every other agency in the country in your cohort, the cohorts being separated into small and large, which we're going to talk about later on. So in these linear exchange function calculations, these percentages that you see on the far left are the up and down percentages that would hit this these agencies' payments. This is specific to the 4th year, and this is the large cohort. The small cohort agencies are agencies that do not have enough patients to be required to participate in the HHCAPS surveys. So if you don't have enough patients to participate in HHCAPS, you're going to be in the small cohort. Otherwise, you're in the large cohort with everyone else in the country. So in these numbers that you see on the screen, this was the 4th year of the demonstration, and this was large cohorts only. Now, what I found interesting is this line that runs up, you can see the linear exchange function basically showing us the percentages. The blue line, the 25th percentile, red is the 50th, et cetera. You see those. I find it interesting that Washington State had the highest TPS scores. If we go back a screen, as you saw here, Washington State has the highest TPS scores across the board in all 3 percentiles. But when it comes to the payment adjustments, they're way down here with negative 1.32 in the 25th percentile and only 3.21 in the 99th percentile, where Florida is at 6.12 in that 99th percentile. And so some of this impact is the reality that the agencies in the state of Florida were only compared to other agencies in the state of Florida. They were not compared to the agencies in the state of Washington. And so basically what this entire process does is agencies that do not perform as well, have as positive outcomes as others, are going to have smaller percentages taken or added to their payment, in some cases taken away from their payment and given to agencies that do perform well. And so agencies in Florida that had a 44 total performance score may have done really well because those were the highest scores in their state, where if they had been compared to agencies in Washington State, their payment impact would not have been as high. And so while these value-based purchasing states, to a degree, have some leg up on the other states that did not participate from understanding how the flow works and from understanding and focusing on improving the specific items in the demonstration, they then again were not being compared to all the other people participating, and it's going to make a difference when it is rolled out nationwide. This information is just taking the value-based states versus the non-value-based purchasing states and making some comparisons from 2019 and 2020, which was the 4th and 5th years of the model. So as you can see, from comparing VBP states to non-VBP states in 2019, the scores for the VBP states in pretty much every category except a couple are higher than the scores in the non-VBP states, but very minimal. It's not significant differences at all. And then in 2020, you see an ever so slight increase or higher outcomes also in the VBP states versus the non-VBP states. So again, this could technically make agencies feel that are not in the states that have already been participating, that they're at a bit of a disadvantage. But the reality is there's 2 calculations, which we're going to talk about as we go through this. You have both an achievement calculation and an improvement calculation. And so with the improvement calculation, you have a chance to get reasonably high scores if you've not been doing so well in the current years or in the year that is going to be the baseline year, which is 2019. You will be able to get higher improvement scores because if you really start working on it now and they're comparing it to not so great scores in the baseline year, you can get high improvement scores. And that'll make sense a little more, I think, as we go. This screen is specifically comparing 2 of the states that were in the value-based purchasing model, Florida and Tennessee, their 2019 and 2020 scores. And as you can see, some of them up, some of them down, but the majority of them up between 2019 and 2020, keeping in mind that the major changes we said occurred and affected 2019, but all of those changes already fully implemented. 2020 was the same. Now, as I said already, 2020 is not even going to be utilized as far as reporting of the value-based purchasing outcomes, nor is it going to impact the payment of the agencies in the demonstration as a result of the public health emergency. So as we start pulling apart the pieces that are going to be utilized in this nationwide rollout, this is the beginning list of the items that are going to be included, and we're going to break that down in just a moment to the actual items. Now, there are two normalized composite scores, and this is one of the major changes that happened in the 5th year. So I'm going to go back a screen because I want you to know that the OASIS items, these that you see on the screen, are acute care hospitalization and emergency department are the claims data. These are the two claims data, and the rest of these are the HHCAPS data. We're going to look at the OASIS items in just a few minutes. For the OASIS items, the ones that are individually scored, it is an outcome score for that one in particular item. When we look at these two normalized composite scores, there is one for the items that you see on the screen. These are all scored together. In the first 3 years of the VBP demonstration, these items were scored individually. They are now scored as they are now represented in your total performance score as one individual score. There is a composite change measure calculated for each of these, and then it's all put together. And I'm going to show you how that works in a moment. So this is the normalized composite change in self-care. And then we have the normalized composite change in mobility. And that is inclusive of the 3 items that you see on the screen. Again, these 3 items are scored individually, but then their responses or their scores are compiled to represent one normalized composite score on your or in your total performance score calculation. Now, this is how these normalized composite change scores work. They take the actual, they calculate the actual change for each of these individual questions. And the change is basically looking at the outcome. So for example, let's look at 1800, which is the grooming question on OASIS D1. There is 4 response options when you respond to that question. So a 0 means the patient's most independent, a 3, they're the least independent, and then there's a 1 and a 2 in the middle. So there are 4 options. So when calculating the change impact from the grooming question, they're going to look at, just like in calculating an outcome, what your answer or response was at the start of care or resumption of care. And then they're going to use what that final score was for that question at discharge. And so they take the change that is calculated is based on, so let's say that you answered 3 at the start of care, and then at discharge, they were a 1. So you went from a 3 to a 1. So if you count backwards from 3 to 1, that patient change was 2 points. They went from a 3 to a 1, which is a 2-step change. And they have a change possibility of 3, as you see at the bottom of the screen. Because if you go from 0 to 3 or from 3 back to 0, there's 3 possible options for that question to change. If you go to the bathing question, which is 1830, there are 7 technically, counting the 0. You have 7 possible response options on 1830. And so if there's 7 response options, there's 6 points that can be calculated in the change. So if the patient was a 6 at the start of care and they were a 0 on discharge, you would get 6 points for the change in that. So when they say normalize, that means you have one question that only has 3-point options to change. You have the bathing question that has 6-point options to change. So once they get the scores, they have to put them all together and normalize them so that they all make sense and they're all calculated as one score. Okay. So as we talk about this nationwide expansion, it was announced basically back in January of 2021 that this was going to be a nationwide rollout situation. It officially became a deal to the nation's knowledge when it was introduced in the proposed rule that was issued in July. The original model resulted in an average of a 4.6% increase in overall home health agency quality scores, with an annual savings of $1.4 million to the Medicare program. And please understand that these dollars savings, as we've already looked at, are not specific to funds that they're necessarily taking out of home health agency pockets, because the way the linear exchange function works is you take away from the agencies that didn't do so great and give to the ones that are doing great. But the savings to the Medicare program is, again, because of significant changes in the reduction of hospitalizations and skilled nursing facilities, et cetera. So the 2022 proposed rule did introduce this. Your first year is going to be 2022, again, if this is finalized as it was proposed, and they are going to use a 5% maximum payment adjustment, and that is up or down. So agencies that do extremely poor could technically see as much as a negative 5% or a 5% reduction in future year payments or a future year's payments. And if you do really, really, really well, you could potentially see a maximum of 5% added to your scores. The reality is, as you saw in the linear exchange function statistics I showed you a few minutes ago, the large majority of agencies are going to likely be within the up or down of probably about 2%. There's going to be those outliers, of course, in the 99th percentile. But for the most part, most agencies are going to probably fall within the 2% up and 2% down. So they are not going to use 2020 data, as I have already said. So the agencies that were participating in the demonstration would have had a 2020 adjustment that would have impacted their payments in 2022, and that is not going to happen. So the agencies that are upset about that are agencies that still did really well and would have had an addition to their payment, but that's not going to happen. So they have completely basically erased 2020 from the value-based purchasing public reporting and from the calculation of its impact on payment. So because they're not going to use 2020 for anything, they are going to use 2019 as the baseline year for the calculations of value-based purchasing. And so basically what that means is they're going to provide us, and you'll understand what this means in a few minutes if you're not familiar with the VBP model. They are going to issue achievement scores, improvement scores, and benchmarks. I should have said achievement thresholds, improvement thresholds, and benchmarks from the calculated data from 2019. And 2019 will be considered the baseline year. Now, I also want to say this, and it may or may not mean a whole lot to you, but it's gone through my mind a couple of times. So when we first started the value-based purchasing 5-year demonstration, the baseline year was 2015. When they made the significant changes with those composite scores that we just looked at, et cetera, they made the baseline year for those significant changes to be 2017. The remaining parts of the value-based purchasing calculation were still being compared to the baseline year of 2015. But the changed elements was 2017. And so I tell you that because I want you to hear that whatever we start this value-based purchasing model with is likely going to change every year, similar to the PDGM model. And not that they're changing the entire PDGM model year to year, but they do change things. Like the 2022 version of PDGM is going to look very different from what it looks like today, because they're changing case mix weights of every one of the HIPS codes. They're changing the scores to calculate the functional. They're changing the low and high comorbidity adjustment. So as we have experienced all those changes over the years, and as we know, we routinely, other than during the public health emergency, have gotten updates to the OASIS, et cetera. They're going to update this value-based purchasing model, and it will change from year to year. And honestly, I wouldn't be totally surprised if we didn't see some changes from the proposed rule to the final rule that we expect around the end of October. And so you're going to have the baseline year. And so basically what that means is your outcomes that will be calculated for 2022 are going to be compared to what you did in 2019. And so again, if you did not do so well, didn't focus on, didn't really care about monitoring outcomes, et cetera, in 2019, and your scores weren't great, then when you get to 2022, if you work really hard on those scores and they're compared to a year that you didn't do so great, then you may do okay anyway in improvement scores and being able to show that you have improved over what you were before. All Medicare certified home health agencies in the Medicare program prior to January 1st of 2021 will be required to participate. If you became Medicare certified in 2021, you will not participate in value-based purchasing until you have had 1 full year since your Medicare certification date. And then that 1 full year will become your baseline year as far as comparing data, et cetera. So if you were not Medicare certified prior to January 1st of 2021, you will not be participating in 2022. The baseline or the basis for your participation is going to be based on your CCN number or your P10 number, whichever terminology you want to use for that. CCN stands for your CMS certification number, which is that 6-digit Medicare provider number that everyone has. And so I say that so that you understand if you are a home health agency that owns 5 different provider numbers, each of your provider numbers will be participating in this demonstration individually. Each of those Medicare provider numbers will have outcomes calculated separately, payment impact calculated separately, et cetera. There won't be a putting together of all those numbers. So anybody that might have thought that an agency that had 100 provider numbers is going to have an advantage, they're not going to have an advantage in the calculations because each of their 100 individual provider numbers will have their own outcome calculations, their own payment positives or penalties, et cetera, et cetera. So I just want to make sure we're clear. It is by Medicare provider number. Okay, and so I'm going to go back a screen again. So at the very bottom of the screen, it talks about the volume-based cohorts, which I've already mentioned, but we'll mention again. Nationwide, there will be 2 cohorts, a large cohort, a small cohort. The small cohort will be inclusive of only agencies, again, that are small enough that you do not have enough patients to be required to participate in HHCAPs. And so if you don't have to participate in HHCAPs, you still have to participate in value-based purchasing, but you will be in the small cohort, which includes all agencies of your size. Everyone else, if you are required to participate in HHCAPs, you will be in the large cohort. And again, compared to every other agency in the country. This just talks about the fact that we are going to have OASIS-based measures, CAPS survey-based measures, and claim-based measures. And we're going to look at those now. So this is a screen put together. If you get into the proposed rule, home health proposed rule, you will see where they have laid out, there's probably 4 pages of tables that not only give you the actual measure domain, but it lays out the definition of that domain, et cetera, et cetera. But I put this in a very succinct, summarized screen so we could get all the measures onto one screen for this presentation today. So you see on the left, the quality measure domain that will be used, the name of that domain or outcome, and then the actual data source or OASIS item that will be used in those calculations. Being clear that those first three you see at the top of the screen are specific to individual OASIS outcome calculations, where the remaining ones, the first one, change in mobility, those three items, 18, 40, 50, and 60, will be in that normalized calculation we talked about earlier. And then at the very bottom of the screen, the 1800 section will all be calculated together as one score. And we'll look at in a few minutes how those calculations are going to impact the overall total performance score. Then on the right-hand side of the screen, you see that CAPS is going to be an integral part of the calculation. We'll look at the items that comes from the CAPS data in just a few minutes individually. And then we have the two claims data, which is acute care hospitalizations during the first 60 days of home health, and the emergency room visits without hospitalization during the first 60 days of home health. So when I said to you a few minutes ago that as we progress through the implementation of value-based purchasing, that I'm convinced beyond measure that there will definitely be changes as we continue from year to year. Well, there's no doubt there's going to have to be changes because one of the things that we know is going to change is that the oral medications question is going to be removed from the OASIS. In addition to that, they're talking about removing the outcome measures for acute care hospitalization and emergency room visits and changing that to one individual outcome measure. And so that being the case, if they're not doing the outcome calculations anymore for these items, then how can they be used in value-based purchasing? And so having said that, basically the model that will roll out in 2022, if it's not changed from what it was proposed, is definitely going to have to change by the time we get to 2023. So that was not just a facade or a thought. It is definitely going to have to happen. So I want to talk through the calculation of the total performance score and how that calculation works, at least from a high level, and hopefully it will make sense. So the first item is basically they're going to take the raw data, the raw quality measure score for each of them compared to prior years through two models. So they're going to take your raw, I can't get that word out, quality measure score, and then calculate an achievement score and an improvement score. The achievement score is going to range from 0 to 10 points. So the maximum points you can receive for achievement is 10 points. And then that achievement calculation is going to be compared to the improvement calculation. So you're going to have two calculations again, one for achievement, one for improvement, and you're going to get the higher of the two. Understanding that there is every possibility that your points will be 0. So if you don't do better, at least as good, let me say it that way, if you don't do at least as good or better than you did in 2019 on any individual calculation, you will get 0 points for that particular outcome. And we're going to look at an example of that in just a few moments. So the improvement score, this is a really impactful thing, is calculated. Improvement, again, is your agency, improving over what you did in 2019. So the impactful thing is the change, not only in 2018 for 2019 implementation, Not only did they change those individual OASIS scores to be composite scores, they also changed improvement to be a maximum of 9 points instead of 10. And so in the first 3 years of the value-based purchasing model, there was an achievement score, there was an improvement score. You got the higher of the two, but the improvement score was also 0 to 10. It was not just 0 to 9. They changed it to 9 again in that what would have been the 4th year implementation of the value-based purchasing model. So why did they do that? They did that because there were so many agencies that had really poor scores in 2015, which was the baseline year. And as they progressed through the model, these agencies were improving their scores so much, they were getting really high improvement scores over what they did in 2015. And other agencies who were doing good in 2019 because they were working on 2015, sorry, and they were working on outcomes and they were trying to make their outcomes better, et cetera. They were putting an effort into outcomes before they knew they were going to be in value-based purchasing. So they had high outcome scores already. So when their scores in the next value-based purchasing year was compared to that year, they were struggling to get higher scores because their scores were already so high. And so I referred to the situation as the improvement train, that many agencies were riding the improvement train because they were getting those really high improvement scores over their really bad scores that they had in 2015. That's the way the structure was built. It wasn't their fault. That's just the way it was built. So after those first 3 years, they implemented that the improvement scores were only going to be a maximum of 9 points, and that slowed down the improvement train, meaning agencies that were simply getting those high improvement scores because their scores in the baseline year were so poor, they weren't getting as high as scores now because, again, the maximum was 9 points. So after we compare the achievement score to the improvement score, then they're going to be assigned a performance score, which I will show you how that works in a minute, all put together into your total performance score. And now, after you have this total performance score calculated, that then goes into the linear exchange function calculation to determine how it's going to impact you from a payment standpoint. And I'm going to show you those scores or how that's calculated in just a few minutes. So when we talk about this total performance score, many would think possibly that each of these individual components that go into the total performance score would have equal weight from one to the other. That is not the case. Should it be the case? Maybe, but it is totally not the case. And so first of all, we have the weight of each section of your total performance score. So again, we have claim-based measures, we have OASIS-based measures, and then we have the HHCAPS-based measures. And so the claims-based measures is going to represent 35% of your total performance score. OASIS measures together will make up 35% of your score, and HHCAPS is going to make up 30% of your score. Claims-based measures, there are only 2 of them. That is acute care hospitalization and emergency department visits. Those 2 items alone together, I shouldn't have said alone, but those 2 items together, that category with just 2 items in it, represent 35% of your total performance score. That is huge. And that was another change that happened after the first 3 years of the value-based purchasing model. They are also changing within the OASIS measures. They are changing the weight that these normalized composite scores for both mobility and self-care were calculated. In the original demonstration, you could get 0 to 15 points for the normalized score for self-care, 0 to 13.5 points. Well, that was 0 to 15, sorry, was for achievement, 0 to 13.5 points for improvement. In the nationwide rollout, they're changing that to match the others so that your achievement score is going to be 0 to 10 points and your improvement score will be 0 to 9 points. So they're putting them, these normalized scores, while they may be 6 questions in one or 3 questions in one, they're putting them still on the same playing field as far as the number of improvement and achievement points they can attain. Okay, so this first screen in the calculations show how the achievement score is actually calculated. So there are 3 components of this calculation, which include the agency's performance score, the achievement threshold, and then the benchmark. So what do those numbers mean? So the achievement threshold and the benchmark are all going to be numbers that we are supplied by CMS based on the nationwide data. Basically, they're going to take everyone's data for these elements included in VBP from 2019, and they're going to calculate what it would have looked like if we had done value-based purchasing in 2019. And they're going to issue the achievement threshold, and they're going to issue the benchmark. The benchmark is the high, lofty, really high score that if you exceed that benchmark score, as you'll see in an example in just a minute, you automatically get 10 points. There doesn't need to be a calculation of achievement or improvement because you have already exceeded the high, lofty benchmark score. So you automatically get 10 points in the calculation for that item. So we do not have these numbers yet, and they said in the proposed rule that we would be given these numbers as they become available. Doesn't that make you feel excited, right? So any of you that have access to a system that would help you calculate what you would look like or could look like in the overall outcomes, you're not going to be able to go as far as calculating the actual performance scores and threshold, the performance scores and linear exchange function without having this data. Now, obviously, there can be projections made based on previous data, but not the actual numbers. So basically, they take your performance score, which means the calculation of that measures outcome score for the current year. So the first year being 2022. So when they're making these calculations, they're going to take your outcome scores for that time period, subtract it from the achievement threshold that we haven't gotten yet from 2019, and then they're going to divide that number by the benchmark, the high lofty score minus the threshold, and then multiply that by 10. And that is going to give you a score from 0 to 10. That will be your achievement score. Then they're going to calculate your improvement score. So as you can see, we're already starting at a disadvantage of sorts with the improvement score, because the improvement score is a maximum of 9 points. So they're going to take your performance score, and then they're going to subtract that or subtract from that the improvement threshold. And so the improvement threshold is also a number that's going to come from 2019, but that's going to be your agency, your provider number's individual improvement threshold. In other words, it's going to be the improvement. It's going to be the scores from 2019 for your individual provider number that you would have to exceed in order to get improvement points. So your current year 2022 score, from that they will subtract the improvement threshold number, and then they're going to divide that by the benchmark minus the improvement threshold. Then that number will be multiplied by 9, and you will have a score from 0 to 9. And then again, that improvement score is going to be compared to the achievement score, and you're going to get whichever of those two scores are the highest. Okay, we're going to talk through some examples of how these calculations will apply. So the first example, and these examples are straight out of the proposed rule for 2022. So you can get those, you can get the proposed rule, you can look through the language, but I've copy and pasted the examples literally from the proposed rule. So the first one, we're going to look at the figure 4 in just a second. Shows the score of Home Health Agency A. Home Health Agency A in 2022 has a performance score for dyspnea of 98.348. Both 2019 achievement thresholds and benchmarks, this number 98.348 exceeds both the 2019 achievement threshold and benchmark, which means the agency automatically earns 10 points for achievement, and you don't even have to calculate improvement. So this is what that looks like. In this example, you see that this achievement threshold, which again is an example, if it were 75.358 and the benchmark, the high lofty number, is 97.676, and your current year score is 98.348 for that item, you automatically get 10 achievement points and don't even have to calculate improvement. The next one is a little more detailed. So this agency B, in their performance year 2022, had a measure, the dyspnea measure had a score of 52.168 for the baseline year, and increased that. So I read that wrong, sorry. So the dyspnea measure score for 2019, the baseline year, was 52.168. They increased that score to 76.765, which is above the achievement threshold of 75.358 for the 2022 performance year. So now we have to calculate, since they got over their achievement threshold number, we have to calculate their achievement score and their improvement score. So you see the calculation, 10 times the numbers that we looked at a few minutes ago, the achievement, the performance score minus the achievement threshold divided by the benchmark, which is 97.676, minus the achievement threshold. That calculation gives the agency an achievement score of 0.63025. Then you calculate their improvement score, starting with a baseline score of 52.168. They now have in the performance year a score of 76.765. So when you make the improvement calculation, you see that they have an improvement score of 4.864. So the improvement score, again, is comparing your score to what your improvement or what your performance score was in in 2019, which was 52.168. And in that calculation, you see that they have an improvement score of 4.8. So what happens, you see they got over the improvement threshold score and less than the benchmark. So they're going to make those two calculations we just made, and they get the higher of the two scores, 0.63 or 4.864. So they're, of course, going to get the 4.864 points. The last calculation, number 3, I put these in the wrong order. So I'm going to skip a screen, go to the example, and then we're going to go back to the diagram. In figure 5, the Home Health Agency C yielded a decline in performance. Their self-care measure fell from 70.266 to 58.487. So in their 2019 year, their score was 70.266, but in their current 2022 year, their score dropped to 58.487. The performance during the performance year was lower than the achievement threshold, and as a result, they're going to get 0 points for improvement. They would also receive 0 points for achievement, sorry. They will also receive 0 points for improvement because the performance year was lower than their achievement threshold. So if we go back to the screen, you see that the achievement threshold is 72.358, the benchmark 97.67, and their current performance score, their current performance score at 58.487 did not get to at least their score in 2019. So they get 0 points for that particular item. Now, this next screen also comes from the proposed rule and gives you within each of these elements the percentage impact that each of these items have on that category. So this is even a little bit scarier than what I told you earlier. You know, I told you earlier that the claims data, which only has 2 items in it, make up 35% of your score. But within those claims data, you see right here, claims on the left, it says ACH, which is the acute care hospitalization, and then the emergency department use. Those 2 items in claims, 75% of the score for claims is acute care hospitalization. So the acute care hospitalization score is 75% of the total 35% of your total performance score. Hopefully that makes sense. Within the HHCAPS survey scores, these are the items that come from HHCAPS. I said earlier we'd look at the individual measures. This is a list of them. And so those items on your HHCAPS scores each carry 20%. There's 5 of them. Each of them carry 20% within the 100% of that 30% of your total performance score. That's a lot of numbers. I know it is, but hopefully it makes sense. And then if you go back to the top of the OASIS measures, within the 100% of the OASIS measures, 25% is self-care, 25% is mobility, and the other 3 items are each 16.67% each of the total OASIS impact. So the one that just blows my mind the most, and this is basically what they did with the significant change they made after the 3rd year of value-based purchasing, is them taking that acute care hospitalization score and making it in conjunction with emergency department 35% of your total performance score. Basically making things that you don't have as much control over to be a higher percentage of your score. So in other words, OASIS, you basically have control over making sure those responses are accurate on the OASIS document, right? But acute care hospitalization and emergency room, while you have some control, you don't really have control of your patients calling 911 in the middle of the night or going to the emergency room. And then the HHCAPS data, you obviously don't have total control of that. You have control over the fact that they have to be sent out, but you don't have control over the responses necessarily. That you can impact them, obviously, but you don't have total control of that. Now, this screen can be really confusing if you don't understand what it means. So hopefully I will be able to help explain. So when they put together your total performance score, you're looking at this very first item or the very first column that says all measures. So in the initial calculation, your OASIS is going to make up 35%, as we said earlier, and this is how the percentages roll out to 35%. The claims measures the next 35%, and then the remaining measures make up the total 30%. So 30%, 35, 35 is 100% of the score. In order for you to get scores in these last 5 items for HHCAPS, in order for you to get that 30% score, you have to have at least 40 HHCAPS surveys returned to them for calculation of the outcome. So if at least 40 of them do not get returned in the time period they're making the calculations, you will not get scores for HHCAPS. So that brings us to the next column that says no HHCAPS. That would then make your OASIS information 50% of your total performance score, and claims measures 50% of your total score. I'm going to be honest and tell you, I cannot remember what number of claims you have to have in order for it to calculate this middle number. But if you don't meet the quota for the claims based measures, OASIS would be 53.8% of your score and CAPS would be 46%. And then if you didn't meet the claims data requirement or the CAPS requirement, 100% of your total performance score would be from OASIS items. So that's what this is about. Hopefully that made sense. And now we're going to look at calculating your total performance score. So I've got, this is a column 1, 2, 3, 4 is for this screen. And it is numbered, as you see, column 1, 2, 3, 4, it is numbered based on this chart. Number 1 is the quality measure. Number 2 are the point measures. Number 3, the weights of each of those, and then the weighted points to get to your total performance score, in this case, 46.021. So the first score is going to be the points. So when we calculated a few minutes ago, an achievement score and an improvement score, the two are compared and you get the higher of the two. And so this column that represents points for applicable measures is the score that you receive the highest of achievement or improvement. It's not a combination. It's not one or the other. It's only one or the other after it's been compared. And this is the higher score of the ones that you have. Then they take those points, again, achievement or improvement, whichever is higher, and multiply that by the proposed weight percentage to get us to the weighted points on the far right-hand column. Then all of those points are added together to get us to a total performance score, in this example, of 46.021. I hope that made sense. You should have a question box at the bottom of your Zoom screen if you need to type in a question. Okay, so I want to make sure that we're clear about these percentages because it is a little confusing. And if we go back a couple of screens, this is where the numbers that you see on that last page come from. So when we were talking on the other screens, I'm going to go back another screen right here. So when we look at this screen for OASIS, this percentage on this screen is just the percentages that they're saying self-care makes up 25% of the total score for that section, not 25% of your total performance score. So I just wanted to make sure that was clear. And then when you get to this next screen, you see that the OASIS measures make up 35% of the score, as we said earlier. So the distribution has to be done based on 35%, not 100%. So hopefully that makes sense. As you can see to the far right, this fourth column of numbers, if you didn't have claims data or you didn't have HHCAPS data and 100% of your score was OASIS, then you'd see those 25 numbers. But as long as you have data for each of those, this is the actual percentage that is applied in the calculation of the total performance score. I just want to make sure we were clear. Okay, then we get to the linear exchange function. Now, this is where it gets really crazy, especially if you don't consider yourself to be a numbers person. So the linear exchange function puts every home health agency that is participating in your cohort. So you see on the screen, it's almost comical. There's 8 home health agencies listed. Obviously, this is an example. That's going to be more like 10,000 home health agencies, maybe less, but close to 10,000 agencies listed on this calculation, 10,000, right? And so these 10,000 agencies will be listed. Their first column of numbers will be their actual total performance score. So on the previous screen, we had a total performance score of 46.021. That is the score that would be listed in that TPS column. Then the next step in this column C2, they are going to list your aggregate home health agency payment amounts for the prior year. So if if they were making these calculations for the first year, 2022 of the model, they will be using dollar amounts, payment amounts, your home health agency provider number received in 2021. So the calculation is made for 2022 total performance score, but the dollars are going to be what you were paid for 2021. Then they're going to take that C2 number and multiply it by 5% to get to this payment reduction amount, which basically means if you had reimbursement in 1 year of $100,000, you have 5,000 of that dollars technically at risk in the calculation of the up or down of 5%. So if you got a total 5%, if you got $100,000 again next year, $5,000 would not happen in your payments. Okay, so they take that total payment amount for the full year, multiply it by 5% to get C3. Okay, then they're going to take C1, this total performance score number, divide that by 100 to putting it into a percentage calculation, and then multiplying that by the C3 dollars that you have at risk, giving you this number. So they're beginning by taking this total performance score, beginning to apply where that's going to put you in conjunction with everyone else. Then they take C3, which is the grand total, the sum of C3, the grand total of all of the money that's at risk, the 5% calculation. They take that grand total, 172,611, and divide that by the sum of the adjusted total performance score, adjusted reduction amount, this 89,397, and that gives them a linear exchange function of 1.931. Now, obviously, that number is going to be different every year with every calculation because it's going to vary based on agency payment amounts, et cetera, et cetera. So when we get this 1.931, that's then going to be multiplied. This is C5. That's going to be multiplied by this TPS reduced amount, reduction amount calculation in C4. And that is the result here. So that's your final TPS adjusted payment amount. So these are the payment amounts based on your total performance score. The $5,000 that you would have had at risk has now turned into $3,669. They take that number, C6, divide it by C2, which is the payments you originally received to get a percentage. So basically what I was saying. And then they're going to take that number and subtract from it 5%, which is the amount you have up or down. And when they take 5% and subtract 3.669, actually they take 3.669 and subtract 5%, you're at 1.331 negative. So your payments in 2024, if this were your agency, you would get a reduction of 1.33% on every single payment you receive for dates of service in 2024. Now, I want you to see this. This agency had a TPS score of 85. Their total Medicare reimbursement for a year, $653,000. That turns into a positive 3.2%. Now, did they get a positive 3.2% because they're a huge agency? No, they got a positive 3.2% because their agency had a total performance score of 85. This agency right above them that had $800,000 had a total performance score of only 22. So that total performance score of 22 brings that agency down 2.86%, 8.76% for the coming year. So every payment they receive in 2024 is going to be reduced 2.876%. So I wanted you to see that it is not based on the size of your agency necessarily, whether you're going to do well or you're going to do poorly, But when you do well or do poorly, it's going to come out in the wash. That's why they do this linear exchange function calculation, to put everybody on the same playing field. So no matter how large or how small you might be, you still have the chance by going through this linear exchange function calculation to come out in a positive light on the other side. You can see that comparison again in the score of 74 for an agency with 660,000 at a positive 2.1, and a score of 25 for an agency at 564, a negative 2.586. So to be honest, agencies that are larger agencies that have really poor scores, their calculation of this impact of course, is going to be much higher and more percentage to be distributed among other providers that have done well. So hopefully that makes sense. And we'll answer some questions in just a minute. So the last thing we're going to talk about before we answer the few questions that we've had come in is the reporting time frame. Now, this will really get you started up. If you have not been participating in the pilot before, you will be blown away at this, because it's a little mind-boggling. So you will not get the first report of what's actually going on with the total performance score calculations until July of 2022. So you're going to be more than 6 months in to this program before you get the first report. And that first report is going to give you OASIS-based measures 12 months ending 3/31. Well, I thought it was only for 2022. It is. But they are using a 12-month rolling 12-month calculation so that they have 12 months of data to make sense. Because think about it, if they tried to calculate outcomes based on just 3 months of data, would they have anything? The reality is, would they have starts of care or resumptions of care and discharges in that small time frame that they would be able to actually calculate reasonable information? And the answer is no, they wouldn't. So they do a rolling 12 months. This is also the point at which you need to hear me say, you cannot take a report. Let's say you get the report in October, which is technically going to go through 6/30 of 2022, and look at any other outcome report, CASPER reports, or that kind of thing, and say, this doesn't make any sense because these don't reconcile. You can't do that, because your CASPER report or whatever reports that you might be looking at might be real for the current 6 months, where this is a rolling 12 months that includes the prior year. So you really need to think about that and make sure you understand it's a 12 rolling months. Also understand that even as we progress to this last screen and you see that your total performance score annual report that will show your payment adjustment that you're going to get for 2024, you're not even going to get that report until August of 2023. And that is the first time, basically, that both the OASIS-based measures and the claim-based measures will both line up with each other, being 12 months ending 12/31 of 2022. Every report you receive prior to having a full 12 months of that data, your CAPS data and claims-based data is going to be 3 months behind the OASIS-based measures. So it is honestly literally impossible unless you have someone making calculations for you in the form of an EMR system or a system like SHP, et cetera, that helps keep those live numbers working as you move through this process. So we do have time for questions, and we do have a few questions in the queue. If you do have a question, please do type it in the question and answer item that's at the bottom of your screen. So someone asked, am I correct that the risk adjustment is not factored into the self-care and mobility items when calculating scoring? I honestly, truthfully, cannot answer that question. I am not sure exactly how the risk adjustment is applied. I apologize. Will your slides be available after the presentation? Yes, you should have received a link to the slides when you receive the email with your login information. Please email us if you did not receive those handouts. Is this for Medicare, or Medicare and Medicaid? Very good question. So the answer is the payment adjustment that you will receive, either positive or negative, at the end of the calculation will be applied only to your traditional Medicare payments. However, the outcomes that are calculated as a part of the VBP calculation, so in the OASIS measures, for example, are going to be every patient you have to transmit an OASIS for. So Medicare, Medicare Advantage, and skilled Medicaid. So if you have to transmit the OASIS for the patient, it will be included in the outcomes calculations. And that's really frustrating for agencies that have a significant high percentage of Medicaid patients. I get it. Do you think this will affect the weight of the star rating, since a lot of the measures overlap with that program? It may be difficult to stay high on the star rating. So it's not going to impact the star rating in the sense that it in any way will bleed over into your star rating. I think that some may see an improvement in their star ratings because of them working on the outcomes that do overlap. But it is not going to have a direct impact on the calculation. So it's a completely separate calculation. Your star rating is calculated over here. Your VBP calculation is happening over here. While there may be some overlap in numbers in the VBP states, we probably saw some improvement in star ratings in some of those agencies. But it is not necessarily a foregone conclusion that just because you have a high star rating now, that you're going to do significantly well in VBP. Where do you find our calculations after CMS implements this? I'm assuming you mean your calculations as far as your outcomes, et cetera. You will have to register in the value-based purchasing portal before it's implemented, and whoever has access from your agency to that VBP portal is the one that will receive all of the reporting, and that last two screens were the reporting scale as far as time is concerned when you'll receive those. How does this affect agencies that have Advantage plans based? So if you have primarily Medicare Advantage plans, you will have a calculation because you have to submit OASIS, right? If you're a Medicare certified agency, you're going to have a calculation. But if whatever percentage comes out again, that's going to impact your payments, that's only going to apply to your traditional Medicare payments. Yes, there is a recording of this call, and everyone that registered for this call today will receive a link to the recording with the handouts. I think someone's asking, what if you didn't get a payment adjustment? I'm not really sure what that means. I'm assuming you participated in the 5-year pilot. And if you participated in the 5-year pilot, you would have received a report every year. And every year that would have affected your payments for the next year. Many of you may have received a calculation for 2020 and showed what your payment adjustment was going to be for 2022. You can basically ignore that because they're not going to publicly report those 2020 examples, and you're not going to see a payment impact in 2022. They will send us a link to the value-based purchasing portal. Someone just asked where that was. You'll get a link to that with all the information about registering when the time comes. The annual report, as I said earlier, will be in the value-based purchasing portal when you see that coming. And I'm still not sure what this comment is about if we were adjusted down. You probably need to email me about that. Can we find out our cohort now? Your cohort is going to be large or small. If you currently, your provider number is subject to having to participate in HHCAPS, then you are in the large cohort and will be compared to every other agency in the country in the large cohort. Will these TPS scores or other scores be made public, like on Medicare.gov? There will be public reporting of the value-based purchasing scores. I don't know that they will publicly show the linear exchange function and payment up and down, but the total performance score, at least it's our understanding that you will see those publicly, but we don't know what that rollout looks like exactly yet. I do not know if they are going to identify agencies by name or PTAN number. In the reports, you're going to get an individual report. As far as public reporting is concerned, it will likely be published by PTAN number. Do we need to worry about 2021 outcome scores? No, your 2021 outcome scores at this point are not going to impact anything. As I said earlier, they did change the baseline year for some items as we transition through that 5-year model. So at some point, they could change the baseline year to 2021. And if they were to do that, then obviously the 2021 scores would impact the calculation of improvement or achievement. But at this point, 2021 will have no impact. What is the TPS score where an agency doesn't experience a penalty? So I don't know how to answer that, to be honest, because we're now looking at a nationwide comparison of all agencies in the nation versus a state by state. But I can tell you that if you wind up in the 50th percentile of scores in the overall scoring calculation, you likely are going to wind up at or around the 0 point. But until we get some nationwide numbers, it's going to be hard to just give you a score, a total performance score that's going to have you wind up in that category. Risk adjustment, sorry, someone's asking about that again, and I honestly can't answer those questions. Could I clarify that acute care hospitalization and emergency room visits will or will not be calculated into the scores for Medicare Advantage patients? So my understanding is it will be Medicare patients that are the acute care hospitalization and emergency room visit patients, and that the OASIS scores are for anyone you have to transmit OASIS for. But I can't guarantee that 100%. That was all the questions in the question box, but I do have some that came in the chat, so I'm going to try to look at those now. Do you think this will affect the star ratings? We've already talked about that. What about agency self-reported activities? Is the scoring of these items? No, the self-reported activities are not going to be used in 2022. I'm assuming when you say agency self-reported activities, you're talking about the 3 extra items that were reported in the VBP portal under the demonstration, and those will not be used in the rollout for the entire nation. Let's see. Do you think agencies who have an OASIS scrubber like SHP will fare better than others? If so, why? I don't know that I can necessarily guarantee you that if you had SHP or one similar to it, that you would necessarily do better. I will say that SHP has some amazing reports and calculations, and some SHP agencies have reported that they have even had calculations going on in their SHP access to tell them where they would be if they were in value-based purchasing while the 5-year demonstration was going on, even though they weren't in one of the VBP states. So I think that a similar SHP or a similar software that is up on the value-based purchasing calculations and forecasting would definitely be beneficial. I don't know that there's any way you could say it would be detrimental, but I'm not going to tell you that I know for sure that if you have one of those, you're going to do better. Is the final percentage payment adjustment based on the previous year's total payments? For example, if the calculation was determined to be 2% add-on of your total last year amount, does that mean you will get no? So if the overall calculation that comes out after that linear exchange function is calculated as we saw earlier, where we saw the plus or minus percentages, those are going to be applied to next year's payment. So every single payment you get, every single final claim you send in for payment will have that adjustment applied to it. So similar to the 2% sequestration adjustment that we currently are not having because of the public health emergency, but every payment during sequestration, every payment that we receive for every claim that we file has a 2% reduction when sequestration is in place. That will be exactly how this is handled. So if your calculation comes out from 2022 to be a positive 2%, then every single payment that's processed in 2024 will have 2% added to it. Hopefully that makes sense. And I think that is all the questions. We had a couple more come in the question box. Will you send a written response to the questions separately? No, sorry, we do not plan to do that. But again, we have recorded this and you'll be able to see the recording or get the recording. Are you going to get notification to register? Yes. So they'll, as we get closer, they'll send out instructions of how to register in the value-based purchasing portal, how to access it, who needs to have access to it, how to get the reports, those kinds of things. To be honest, it might even be closer to March. I'm not guaranteeing you'll get it in January, but you will get the information prior to the first reports coming out, which should be the end of March. Yes, 2019 is the baseline year. So anything that they're doing in calculations in 2022 to compare your scores for achievement and improvement will be based on your scores in 2019. So that does finish up the questions, and it really does finish up the time that we had allotted for today. So I want to thank you all for participating. We had a great crowd. Please let us know if you need any additional information from us. Please feel free to send us questions, etc. We will help as much as we possibly can. There obviously will be updates as we approach January of 2022. When we get the final rule toward the end of October, there may be changes even in that final rule. If there are any significant changes between now and January 1st, we will have another webinar. The National Association for Home Care and Hospice is also working on education that will be rolled out nationwide. Thank you again for not only participating today, but thank you for being on the front lines and caring for patients during this current public health emergency. Thank you all and have a fabulous weekend.